Good morning, everybody. It's wonderful to see you here this morning from wherever you are, wherever you're calling in from. I hope everybody has a cup of coffee or their morning beverage. But the conversation will certainly stimulate you and keep you awake as well. So we're really excited to have you all. I'm Sheila Maroney. I'm the executive director of the Patient Revolution, and I want to. You've heard Maggie introduce herself as the program and creative director. And Samhar is here. There's Samhar Haptan, who is our community engagement and communications manager. So I want to just thank them personally for all the work that they've done to put this town hall together. And Victor will introduce himself after I offer a few introductory remarks and introduce our special guest this morning. So I just wanted to, for those of you who are new to the Patient Revolution, those of you who may not have joined us for a while, I just wanted to set the context for this morning's conversation. And I have a couple of slides that I want to share. So I hope that this works. Loading. There we go. So just as a reminder, again, for many of you who are new and who it's always really good to restate who we are and what our mission is to make sure that we're all aligned. So the Patient Revolution serves as the backbone for a global movement that turns away from industrial healthcare and turns towards careful and kind care for all. We have a theory of change, which is to bring about this radical change, that the Patient Revolution will cultivate and equip a global community who each act locally and together to bring about the conditions for care. And when we talk about a global community, that's all of you on this call today, as well as the other about 2,200 people who have joined the community thus far. And what we do is we work with all of you to help the care activists who join the movement stand up for care and work to change the way that others and that they talk and think and make decisions about how healthcare is designed, delivered, and paid for. So our framework for care is moving from the left-hand side of this chart, which is the pathologies of care or the manifestations of industrialized healthcare, which include blur and burden and hurry and cruelty. And we are trying together to move towards an environment where the signs of care are predominant. And those include unhurried conversations, seeing patients in high definition, which is understanding their biology as well as their biography, making sure care fits each person's unique situation, and working to reduce the burden that patients have patients and their families and caregivers have increasingly come to experience in the healthcare system today. So to do all of that, we've established strategic priorities to help us keep focused. And the first one is to build this community. And again, that's all of you. It's people around the world who are working to turn away from industrial healthcare in their own local area of influence to bring to life careful and kind care. The second is the school, which is our strategy to equip you all with knowledge and tools and inspiration and an opportunity to learn and share with one another so that you are empowered to stand up for care. The third is what we call our greenhouse, which is our think and do tank. And I would say that the emergence of this town hall forum, where this is our second forum, we launched it in 2024, and the town hall really touches on all three of these strategic priorities. It is a convening, it is an opportunity for all of you to come together and to bring people who are new to the Patient Revolution to an easily accessible event. It is about teaching and learning from each other. And then it is about really bringing together thought leaders who are going to help us dig into the important topics of the day. And today's topic is primary care and making care primary. And then we always, a strategic priority always needs to be to build our infrastructure so we can sustain this organization, and not only sustain it, but expand its reach and its impact. And so I'm going to put in a shameless plug today. The town hall, as all of our programming, is free to everybody. We want to ensure that it is accessible to whomever wants to join us. And so we need your support. And we need the support of others you might know who want to invest in a future of careful and kind care. So you'll see in the chat an opportunity to contribute and pay it forward so that we can keep these forums going. So as I mentioned, this is how we think about our work. So what you can see is that the global community is the dominant force for change. And again, that's all of you. We collaborate with each other. We foster collaboration amongst you. We have launched a mini revolution prototype, which is an opportunity for us to understand from you, what do you need when you are trying to make change happen, and how can we support you? We have a fellows community to which you are all invited, and that's a group of people. At present, it's about 110 people, again, all over the world, in 15 countries, representing all aspects of healthcare, who have made an additional commitment to participate in the work and the evolution of the patient revolution. And we convene events and gatherings so that our global community can become enriched and inspire one another. And the school supports all of this work. The greenhouse supports you as well. So this is a picture of a loosely framed picture of where care activists are around the world. So these are, imagine big dots. There's East Coast, there's Midwest, there's West Coast in the United States. We're in South America. We're all over Europe. This is just the sort of high-level representation. What's really, I think, fabulous for today is we're talking about making care primary, and how does the conversation about primary care fit into a future agenda for the patient revolution, and how we might set a policy platform. And digging into the word, everybody throws around the word policy as if we might all know what it means. And in fact, it comes from the root word, the Latin root of citizen. And so I think it's very appropriate that some, I don't know how many people so far, 50 people have joined us, citizens from all over the world. And again, the several thousand people who have joined our community are citizens all over the world who are working together to change the conditions for care. So what's going to happen today is you're going to gather in small groups after Victor and Asaf have a conversation about primary care. And you're going to talk, we hope, about how primary care might fit into a policy agenda for the patient experience, and, excuse me, for the patient revolution, and how, what other topics might emerge as our policy platform. So with that, I want to turn it over to Victor Montori, our co-founder, whom I assume most of you know. And I'll let Victor introduce himself and the topic today, and then introduce our special guest.
Thanks, Sheila. Thank you very much, and thanks to the team for organizing this town hall, and thanks for everyone for coming. And as Sheila mentioned, I'm Victor Montori. I'm a physician and researcher at the Mayo Clinic in Rochester, Minnesota, in the United States, and work with Sheila, Maggie, Samhar, and others in this community to bring about careful and kind care for all. The goal of today is to help us think through and obviously land on a set of, very few, 2, 3, 4 areas of policy advocacy that Patient Revolution could implement. We have not gone there up to this point. We have been focusing on what is it that we want to see in the world? And while most people are talking about access to it and how to pay for it, we've been focusing on what it ought to be and defining what care ought to be, and then use that to justify how might we open up access for everyone, and how might we then afford it by looking at innovative models of care and delivery and organization, and to focus on those areas. What are policy areas that we should focus on? And to better understand healthcare policy and delivery, we have a series of very senior advisors, international advisors that are helping us think through that. One of those advisors who early on said, I'm gonna support what you're doing, and I'll do whatever I can to help you out, is a Rochester native, Rochester, Minnesota native, like my sons, who has had a phenomenal career, both as a primary care physician and a primary care researcher, as well as a leader in international and global change in healthcare. Asaf Bitton is executive director of Ariadne Labs, which is an innovation center in Boston, linked to Harvard and the Brigham Women's Hospital. He's associate professor of both medicine and healthcare policy at Harvard, and he has been advising the U.S. federal government in a number of instances, including the Agency for Healthcare Research and Quality and the Center for Medicare and Medicaid Innovation, particularly around the topics of how might we pay for primary care, help primary care organize itself better, and how might achieve some goals for communities in the United States. And one of the topics that we've been talking about, Asaf, in terms of policy platform for patient revolution, has been brought in part by Kevin Grunberg's paper about primary care being a commons, is should patient revolution have as its first policy platform primary care for all? And we can, in the course of this conversation, try to define what that means and specify it a little bit. But maybe that's a place to start. Why would anyone want to make sure that every single person has access to some form of hopefully a very good form of primary care?
Well, thanks, Victor, and it's nice to be together with everyone today. The work that you're doing and the work of this community is so critical and so central and so aligned with the things that I'm passionate about. To answer your question, primary care at its core form is an interconnected set of functions. It's not a service line like cardiology or a type of nursing practice or physical therapy. It's a set of functions that are carried out by teams. And those functions include the ability to have first contact access to the majority of health conditions that can be cared for by a primary care team. It represents the ability to be known and seen over time, this principle of continuity, the ability to form long-term healing relationships with people that you trust as a patient and who see you and who allow you to be seen. It's the function of coordination, which allows your information, your story, your history, your needs, your preferences to be shared and cared and transferred over time with your consent, and so that you have an integrated experience as you move through different phases of the health system or the systems that create health outside of healthcare. And it's the function of person-centeredness that really centers the idea of you as a holistic entity, as a person, as an individual located within a family and a community, as opposed to a diseased organ state that happens to be falling apart in one very narrow sense. So those interconnected functions really make up primary care. And when those functions are met in an integrated, person-centered fashion, we have grade A+ evidence that better health and better equity and better outcomes ensue. In fact, primary care as a set of interrelated functions, when they are provided and when they're paid for, is the only part of the healthcare system in which investing in it routinely results in both higher life expectancy, more equity, and better health outcomes. It's not to say that you shouldn't invest in any other part of the healthcare system, hospitals, ERs, what have you, but you just can't expect those three things to happen. You maybe expect one of those three things to happen, or you maybe expect a sick care system to happen that will manage a crisis, but not necessarily create a partnership for health. And you don't have to believe me because I'm just a person. You can believe, 50 years of research led by people like Barbara Starfield, who is sort of the grandmother of the research movement around primary care. You can read all sorts of World Health Organization reports that over and over find the same thing. You can read the recent National Academy of Sciences, Engineering, and Medicine report on primary care that found the same things. So primary care results in better outcome, more equity, and better life expectancy, but it is failing in the US, and maybe that's something, and really around the world. So maybe that's something that we want to talk about.
Yeah, so if I failed to mention that Asaf doesn't have one but two awards named after Barbara Starfield that he's received, the latest being the Leadership in Primary Care Award. And the principles that you were using to articulate what primary care is, I believe, were if not initially specified, made famous by Dr. Starfield.
Yeah.
One of the so let's take that as a given, which I like to fashion myself as an expert in evidence-based medicine. I find the evidence about primary care improving outcomes, reducing costs, and impacting health very compelling. Why is it that enlightened, socially solidarity-based countries, I don't know if that's a definition I can use. I'm thinking of Denmark. I'm thinking of the UK broadly, maybe Spain, Italy, Canada. Why is it that these countries seem to either take primary care, which they set up their system as the basis for, they set up primary care as a foundation for their system. Why do they seem to take it for granted? And how is it that austerity policies in those countries seem to have made it very, very difficult for primary care in those places to actually play that fundamental role? And why is it that in those countries we've seen sort of a tendency towards a Americanization of their system, where there's more investment in big, flashy hospitals, technologies, and specialty care?
Ooh, that's a big question, sort of cross-continental, trans-decade socio-political health policy. So I'll take a very meager stab at it. I mean, the countries in question all have a sort of different trajectory to why they came to privilege and invest in primary care principally. And we may have callers or folks on the phone that are that live in or from those countries that can add to the discussion. But whether it's in the UK, post World War II, with beverage policies and setting up the NHS and a rational system. And actually, the idea of primary care as a level of care comes from post-World War I reports to the British government around setting up a network of first contact accessibility for the majority of people. And the guy who sort of theorized this actually knew nothing about healthcare. He was an education policy person, and the term primary care unfortunately comes from his misunderstanding of it as a simple first layer of care akin to elementary school, and then secondary care is akin to secondary school, and tertiary care in hospitals akin to colleges and universities. And that fault sort of got corrected as the evidence came out in the UK and Canada and the US and parts of Europe around primary care as not being simple, stupid care for the masses, but rather the integrating function where people are seen and known, where public health and healthcare can be merged, where social determinants, social determinants of health were not discovered 5 or 10 years ago, contrary to recent discussions. They've always been a part of these discussions and sort of flowed through primary care, which is a very natural point of intersection between public health and healthcare systems. So to try to, in a meager way, answer your question, a lot of rational health policy came to link the universal accessibility of some basic, not basic in simplicity, but basic in as in fundamental or foundational access to care that serves the majority of a person's needs, that follows them over time, and that connects them to other parts of a social system that helps to create and maintain health, that came to be localized in so many of these countries with very different political trajectories within and around primary care. And so primary care, doesn't have to be a concept. Yes, it's a concept of solidarity, but it's not a concept that's only linked to one political ideology. You see it across a political spectrum, and you see that probably because it has a face validity, it has a utility function and factor, it's an outcomes driver it meets people's basic needs in a way that crosses the political spectrum, and that actually, when you reflect on the US, makes the US even more of an outlier, because the US has made a series of choices to sort of underinvest and ignore and underprivilege primary care that actually make no sense economically, they make no sense rationally, they make no sense socially, they make no sense in the political currents of the last 50 to 75 years, but they are where we are.
Great. So you've given me only a partial answer to my question, so we're going to have to come back to that in a second, because I think that we need to dig deeper on that. But I want to bring in Anna Lewandowski. Anne is one of our Patient Revolution Fellow, and she is an advocate for changing healthcare. And one of the remarkable parts of her story is that she joined healthcare at the age of 6, answering phones and working with patient bills. So, the very precocious entrance into healthcare. And your comments?
First of all, I did see a question about rural versus urban primary care. And I do want to say I was brought in because my parents didn't believe in child labor laws. And so I did see my mom, who is a nurse practitioner, actually providing this exact type of primary care to her patients in rural Northern California growing up. So she knew them, they would walk up to her in the grocery store, and it was really this continuous thing. And because we were in an area with very scarce resources, of course, she wanted to keep them out of the hospital. She wanted to keep them in community. Now, my personal story is a patient with complex diseases. And because they do not present in standard ways, I am frequently considered nuts, right? We all know that many women have the experience of hysteria, which has a very long and complicated history in the medical system. So 2 years ago, I actually switched to what's called a direct primary care. We pay her a very small fee. When I heard her fee, it was 4 visits to my primary care doctor in a system. And we have begun to build a relationship where, instead of hesitancy about, are you stressed? Because when I hear that, it means that I don't have a disease. It means that it's just all in my mind. I can tell her, yes, I am stressed. It really came to a head last week where when I went for a visit for a mammogram, and I had this incredibly long and very stressful survey about my genetic risks, and a mammogram tech telling me that I had all of these risks, even though I had talked with my primary care and I I wasn't in a place where I was concerned about my risks. Now having somebody that I didn't trust put this in my mind completely made me paranoid to the point where when the ultrasound came back negative, I didn't believe them because my body felt different to me. And so what happened is I called my primary care, and because we had this trusting relationship, she was able to say, hey, listen, if you want X, we'll do it because I know your body doesn't present normally, but I think you're going to be okay. And this has happened a couple of times where if you don't have trust in somebody, you may ask them for more, right? And this is really an area of significant interest for me as a patient to look at how does that role of trust impact the economics of health? And I think it's huge because she can say to me, and we don't need to do that extra test. And because I trust her, I'm not pushing, I don't have this nagging doubt in my mind that I'm not getting the best care possible. And I think that's a critical reason to invest in primary care. Because when you're not seen or heard, either you opt out of the system and you have worse outcomes, or you have this nagging feeling and you're continuing to pursue something that may or may not be there.
Thanks, Anne. I think Asaf, there's a number of things in Anne's comment and that I think are important. A couple of them that there are three at least that I've picked up, but I'm going to ask you a couple of them. When people argue for primary care for all, one of the questions that comes up is, but how might we do it in rural America, where it's the population density makes the economics of it very difficult. And then, of course, people jump at, oh, we can use digital. And in many places, a digital first primary care is what's being replaced for the notion of primary care that perhaps Anne and you have been thinking about. You want to comment on that issue?
There's a lot in what you and Anne just said, and Anne, I want to appreciate you sharing your experience and your story. I think better than I can say, it underscores, at least to me, what the value is of primary care. The idea of providing trusted, not just advice. Advice assumes a level difference. It's a trusted companion on the journey toward health that is dynamic, complex, idiosyncratic, scary, exhilarating. You embody in that story, just one slice of I wish, for instance, policymakers and folks who fund healthcare could understand, their conception of primary care is people sitting in a boxy office who give out blood pressure medications, sore throat swabs, and order some tests. And what you talk about is a complex, respectful, bidirectional relationship centered around trust that is perhaps, in a system that is oriented around paying for procedures and tests and throughput and sick care, or what you're describing is exactly the opposite and exactly what most people want and need. So the question around how to do that in a rural fashion, look, there's no easy answer for primary care. There's no one answer for primary care, especially in the US. The first question is a fundamental question back to you all. What's the alternative of not providing primary care in rural areas or any underserved areas? I mean, so less access to complex, fragmented, high-cost specialists who don't have time to follow in a team-based manner patient journeys across all the complexity of people's lives. Is it no healthcare? Is it healthcare when you're completely sick and on your way to an ICU? And we all know the situations with rural hospitals right now and their inaccessibility and their financial structure. So at some level, I always argue, people say, well, why should we fund, or how should we fund rural primary care or underserved urban primary care? What's your alternative? More funding of of a system that's heartless and broken, that looks at people in the face like we do in the US and say, we don't owe you anything. We don't owe you anything in sort of a social compact or a social good in terms of healthcare, except we as a heartless society can't actually take that final step of heartlessness and to its ultimate conclusion and say, we'll allow you to die on the street in front of us. We actually have a law that from 1984 called EMTALA that protects the US public from its heartless outcome that derives from its inaccessible policies that say, you know what, that's just a step too far. Only a few countries in the world do that. And we don't really want to see people die in front suffer in the corner. So if you have a heart attack that was totally preventable, or you have a stroke, we can't handle that public sort of a pronunciation of the violence that we do to people's bodies by denying them care. We will take you in the hospital, regardless of your ability to pay. We will throw you in the ICU. We'll make sure somebody else pays for it at the worst possible time, and sort of cover up this heartlessness that we've encoded into our policies earlier on, as opposed to something much more humane and rational that most other countries do, say everybody deserves access to a primary healthcare team that knows them, that cares for them, that's embedded in their community, that is trained where people live and work. So one of the main answers to the rural healthcare conundrum is to train people where people live and work. That means expanding teaching health centers. It means expanding new state-based medical schools that have a mandate and a very strict policy around 80 to 90% of their graduates going to work in rural areas in the state that funds those medical schools. Those are all doable, complex, but doable policies. But we choose to do literally the most insane thing, which is fund a sick care system that allows this heartlessness, but doesn't take it to its end degree, and then kind of covers it up in the maximally expensive and bizarre, fragmented way that we have it now.
So,
To be blunt.
yeah. The and yet, it's when you think about arguing for a policy of, say, primary care for everyone, and you start thinking about how, how do we pay for it, and then how do we make sure that people who can provide that care are where they are needed and so forth. You haven't responded to the issue of digital, but one can assume that some solution that uses every possible resource available to us to actually fulfill that mandate will probably be on the table. And also mention direct primary care, and I presume all different forms of healthcare economics might work. But this idea of primary care for all assumes that nobody will be left behind from what appears to be the most sensible way of responding to people's healthcare needs. So I'm going to go a little further beyond that to actually ask about something slightly different, and that is, when people imagine primary care, you said they think of somebody looking at somebody's throat and giving out pills for this and that and the other. I presume Walmart thought that, maybe other entries into the primary care space that thought they could make a killing, which is an expression that should not be used in healthcare, economically, are entering into primary care with these retail models and so forth. I think they are probably experiencing some degree of oversimplification of what primary care is. I'm not entirely sure that they're that committed to relationships and understanding and partnership and so forth that you've described. Certainly continuity will be a pretty hard thing to pull off in those spaces. But at the same time, much of the public thinks of primary care as a place for wellness. One of our colleagues in the chat said, "Oh, that's where you go for your oil change, right? And that keeps you going, keeps you well." At the same time, with such a difficult problem of accessing primary care, the focus on keeping people well, one person at a time in an office, seems massively wasteful and plugs up a system that cannot take care of those who are sick. I'm a diabetes doctor. Most people should not be driving 6 or 8 hours to see me, because they should have a primary care clinician that can take care of most problems of diabetes that I ended up taking care of. The fact that people drive that distance is because they do not have primary access to primary care where they are. So is primary care a place for an oil change and a wellness check? Or should it be our first line of defense in relation to disease, particularly chronic disease? And should we push a lot more of that wellness and prevention into the public space, into public health?
I think this is one of the key debates right now in primary care. Some people call it the problem of the general store. Should primary care be the general store for well care, preventive care, acute care, chronic care, rehabilitative care, behavioral health integration? There's a strong argument to be made that properly funded, meaning, and we can talk about, the linchpin to change, I think the structure and role of primary care really starts but doesn't end with payment. It starts with moving away from a particular kind of payment system, but that's not the whole story. So I think that there's a camp that says that well-trained, properly financed primary care teams can, with technology, but not only through technology, care for the majority of people who have the majority of conditions. There is another camp, we call them the segmenters, that say, with the level of complexity and people's needs being this high, no one entity can really care for both a, quote, well 35-year-old person who's mainly seeking preventive care and wellness infused care, and also a person with 14 complex conditions and 17 medications. And so we need to start segmenting people into different kinds of primary care teams. This has a long history. Many sort of business school and business theorists in primary care believe in segmentation as an outgrowth of what works in business. I'm a little bit more toward the holistic camp, but I am well aware and understanding of models of primary care that are directed in partnership with particular populations of patients that have high needs or particular needs. And so again, I'm not trying to skirt your question, Victor. I just don't think that there's any one pronouncement. I have the humility to say there's no one policy, there's no one model. We have a heterogeneity of models in the US. The question is, do we want everybody to at least have access to somebody? Do we want to get out of a piecemeal payment system that only values, both in healthcare transaction and in healthcare interaction, a visit in a physical clinic? Or do we want teams to be given the space, financing, structure, and resources to be able to care for communities of defined patients with a variety of needs over time in a variety of ways, integrating patient perspectives on how those needs are best met? You can probably tell in that latter camp.
So when you sit down in the ante room of policymakers with other advocates, those advocates are from the Diabetes Association, from the Cancer Group, from the Alzheimer's Society. These people are coming in with the disease orientation. Oftentimes, these are, obviously AstroTurf organizations that are funded by industry in the back and so forth, but many of them are eager to actually make sure that there are access and treatment solutions to their particular diseases or problems. And they tend to be extremely well funded. And when the primary care guy shows up, it's like, I do everything. And does that work in those rooms? Does primary care work as an advocacy platform in those rooms, or is it so much more sexy to talk about, I'm going to cure cancer, I'm going to delay the challenges of Alzheimer's, and I'm going to make sure that there is a robotic surgeon in every town. Robotic surgeon, primary care, nurse practitioner, physician. Wow, there's a very different, level of sexiness there. How do we overcome the sexiness problem in primary care?
I think I might skirt the sexual health question because it's a little bit funny to me to sort of people use those terms. I can say though, what I think you're getting after is this idea of what grabs attention of people who pay for and structure healthcare, and what grabs the attention because of a historically encoded way in the US is procedures, therapeutics, and hospitals. And that's because that's the payment system orientation in the US. It's not a rule of sort of healthcare policy law across the world that has to be. Can give you many other examples that sort of say, we can, yes, pay fees and codes for certain procedures, but the base way, the sensible way to pay for longitudinal relationships is to pay for someone's care with and for a team over a year's period. And that is not just about capitation, which has a kind of sordid history, but just basically pay an adjusted amount to enable a team to care for a person over time. Making that argument to care for a person over a course of a year is a lot harder than to pay for a new robot or to pay for a new PET scanner. And that's the problem, is because it's a problem of evidence translation, that people don't understand that actually the care by a primary care team is going to get you more value as defined by better health at same or lower cost than a particular procedure. It is because of the advocacy organizations that are extraordinarily effective at advocating for a particular disease state with a particular disease story or particular treatment. And it's and I will say this sort of to our community in primary care, we've been particularly ineffective, and we've had less than effective urgent leadership at the advocacy and clinician and team and patient mobilization space to sort of say, primary care is basically like oxygen. You only start to notice it in many policy circles when it's at really low or critically low levels. And there aren't very effective oxygen lobbyists. There are really effective other lobbyists that you talked about. And so, this is a particular deficit. This is a role that perhaps this organization here, you all might want to start filling. And it's not really about the primary care clinicians arguing for their slice of the pie. That's actually where the argument gets very convoluted, and just, policymakers say, oh, you're now the primary care folks, you want more money. The cardiologist yesterday wanted more money and the nurses the day before. Go buzz off, all of you. We pay $4.7 trillion to you people and you still want more. Well, no. The argument's very different. The argument is, do you want a healthcare system that's rational, that's more equitable, that actually pays for what people want? Or do you want to sort of be diluted by bells and whistles and robots and zapping and mapping that are a good tagline and have fancy suited lobbyists, but it ultimately aren't really as good of an expenditure as primary care is? Primary care needs a new tagline. It needs, and there are all sorts of, primary care for America and this and that, but there's not been a very effective grassroots organizing function, even though, and I'll stop here, primary care is one of the last things in political healthcare that actually still enjoys incredible bipartisan support. You can walk into, as I've walked in to talk to Republicans and Democrats, and they'll both generally be extremely supportive in the abstract. The problem is in the specific.
So if we were to heed this urgent call and decide that as Patient Revolution, as an organization, we want to have this idea that everyone should have access to primary care, and everybody should have access to careful and kind primary care, not just any old, shop with a AI chatbot that is capable of answering questions and dispensing urinary tract infection antibiotic. If we are to advocate for that, how might we do that? What do you think are the most and I know you're unique, right? You do have a kind of a US in-depth understanding, but you work globally. So this is a global organization to some extent. And I would argue from talking to folks in places that we tend to look up to, like Denmark or Scotland, that they have problems in primary care there that actually are quite interesting, given that they have the public argument that they've made an investment or they're making an investment there. Primary care there is fundamental, but it's struggling to meet the needs of people. They have problems of equitable distribution of that primary care, and they have a huge moat between primary care and specialty care, where patients often get lost as they go from one place to the other. So they have problems too. So what are the 2 or 3 or 4 things that, as an organization globally, and if you feel more comfortable doing about the US, that's okay. What are the 2 or 3, 4 things that should be part of our platform if we're going to go in this particular direction?
You keep asking very complex, they're like onion skins of questions in there, and then you tell me I'm not answering them. So and there's this amazing chat that's happening, and I'm feeling like I'm not answering that. And also, my job is not to answer questions like sitting on high as some expert, but just to give a perspective. Look, the base case for primary care is pretty simple across the globe. This is my area of study, sort of global primary care systems, with, yes, a focus in the US, but we, worked in dozens of primary care systems, country systems in the world. There's a truism that I still cannot negate, the following statement. I have never seen an effective healthcare system, effective defined by good outcomes with equity at a reasonable cost. And nobody's perfect, but there's better and there's worse. There's no effective healthcare system in the world that doesn't have a strong foundation of primary care. It doesn't exist. It's not to say I'm not an anti-specialist person. I don't get into those silly arguments. Everybody in a healthcare system has a role, but as a truism, as a sort of system dynamic, I would challenge anybody to find an effective healthcare system that's meeting its population's needs. Doesn't have a very strong basis of primary care. What are the kind of commonalities underneath that? Whether they range from Costa Rica, where we've done a tremendous amount of work, when probably has one of the top 3 primary healthcare systems in the world, to UK, Denmark. By the way, my understanding in Danish, I don't speak Danish, but my understanding in Danish, correct me if I'm wrong, that the word for primary care clinician in Danish roughly translates to comprehensivist, and the word for specialist roughly translates to partialist. I find that very interesting, but I'll just leave you to think about what the implications of that are. But the fundamentals of a good primary care system are a universal accessibility, and you can get to universality through classic sort of common social insurance scheme to voluntary schemes that mandate people have commercial insurance, to a variety of schemes. I mean, you can do it across the political aisle, but universal access to primary care teams that have a common set of information technologies that can follow people over time and are connected to their care in different parts of the health arena, and that are paid for as a unit time and not a unit visit. And that's where I would argue you have to start with the US. And that's what our National Academies report says. There are 5 things, forget reading a 420-something page report. There are 5 things the US needs to do, and they're in order. And it starts actually with payment. You have to pay for teams to care for people, not doctors to deliver services. The latter is what happens. I said doctors on purpose. A doctor-oriented fee and code and visit-based system around incremental little widgets of service, as opposed to relationships over time. And the teams with the integration and complexity to do that. Number 2, you have to make it accessible and available, whether that's through direct primary care or through expansion of Medicaid or through commercial insurance. That's maybe a different conversation, but there is a route to universality in the US. Many states already have it. It's a political decision. There are lots of ways to get there. Basically, for primary care, you need to take it off the fee-for-service hamster wheel and put it onto everybody has a way to contribute, or to be contributed for, to be cared for by a team over time. Teams need to be trained where people live and work so that everybody has access. Information technology needs to be redesigned so that it actually serves patients, families, and care teams and isn't just a billing structure. And then there has to be an accountability mechanism. There, I summarized a 400-page report for you. I think it's a pretty good report. I think it's a pretty good starting point, and it's actually something that's gained a lot of traction within federal and state governments, which is just a start, not an end. And now I think what it really needs, not the report, but the movement, is a patient and grassroots level advocacy structure around the core idea that there is no high-performing healthcare system without a high-performing primary care system that requires it to be paid, trained, and integrated differently, and that there are a variety of ways to get there.
And you're referring to this particular figure in the report, Asaf, right? And this is the report that you're recommending people to take a look?
Correct. I can put the link in the chat.
Very good. Now I need to get off this screen share here. Hold on for a second. I lost my, oh, here we go. Excellent. Good. So we have, we've heard so far how primary care is fundamental, is oxygen. You take it for granted until you can't have it. It is the basis of every well-functioning system. It is more than simple primary care or basic primary care or entry-level primary care. It is team-based, it is relationship-based, it offers comprehensiveness and continuity of care. In that way, it connects with the principles of the patient revolution focused on getting to know people in high definition, getting to respond to their problematic situation in both terms of biology and biography with partnership, co-creating plans of care that make sense and are minimally disruptive of their lives and loves. So we could have simplified the principles of the patient revolution by saying that we're interested in primary care and we want primary care for everyone. You've identified that the unit, the main resource of that is time. And before we break out and get other folks' input in here, I want to ask you another important resource, and that is people. You've said you moved away from doctors billing for a specific service to team-based approaches with a diversity of colleagues. But there is a challenge in the front lines of healthcare today, which is, of course, is burnout. And and when people are being asked to do things that are not consistent with what they see as their the standard of care they want to give, that leads to moral stress and potential moral injury, and over time, what people are calling burnout and exiting the practice and leaving behind more burnout clinicians to take care of whatever is left, and people without clinicians and without care, having to drive 8 hours to see people like me, God forbid. So what is the humanly sustainable forms of primary care that you've seen that not only are able to meet the needs of the public, but are also elevate the quality of life of those clinicians who commit to participate in such a system?
For primary care in particular, or
yeah,
all?
so in what way? So if we were to push for primary care for all, how are we not committing a larger number of people to a system of care that is going to grind them down until they have to leave the practice and do something else?
Well, you've laid out why the purview, of primary care is almost sometimes, if you think about it, almost just laughably broad, especially with the current workforce and the current structure. Really the majority of people's health needs over time, preventive, acute, chronic, rehabilitative, end of life, we can go on and on, right? So there are at least two ways into this conundrum. On the one hand, again, this is like thinking about the counterfactual. The one hand, like thinking about the current mandate with the current payment system and the current workforce, the marvel isn't that things are so difficult. The marvel is that anything works at all. Now, sometimes it works because people are taking detours and finding creative ways out of the morass of an inhumane system. You know, we heard earlier with Anne about direct primary care, where people literally come out of, you know, care teams are just coming out of this inhuman hamster wheel and choosing for themselves and finding ways with their patients to finance the time, space, and relationships that are craved by everybody. That is one angle, that's one direction. Another, but the core point has to be that more people need more time to provide a broader sense of and a broader definition of healthcare production than we have now. So what we're not trying to produce is more crammed 15-minute visits in which something like 384 certified national quality metrics, that is a true statement, exist for primary care, and somehow take these minimally enhanced teams over the last 10 years and say you have to collect hundreds of metrics and do all these things and be a scribe to yourself and do the billing and also be there emotionally and connectively for meeting patients with, you know, undefined, predefined, poorly defined, complex conditions, mental health, you know, physical health, social health. It's almost insane if you think on one level. On the other hand, there are routes and not blueprints, but compasses and directions for how to build integrated, interdisciplinary, interprofessional teams, and how to sort of demand that a healthcare system that spends enough on healthcare, I mean, almost 5 trillion is a lot of money. And of that 5 trillion, only about 4% goes to primary care. And so you could say, well, what would it look like to double that? I mean, the US would barely feel that. In other countries, Canada and parts of Europe, it's somewhere between 8 and 12%. Again, you could probably double that with some pain being felt across the healthcare system, but not too much, and sort of ask what you could get. Imagine double the funding to expand teams that have time, that have integrated capacities to slow down, meet people's needs, have a relationship as opposed to a scribe and billing function. It isn't a pie in the sky. It's actually like fiscally and policy-wise possible. I'm not creating a tale of unicorns and rainbows. I am saying that primary care would have to be seen for what it is, which is an engine, not the only engine, but one of the main engines for driving health production within an overly expensive, inhumane healthcare system. And I think we can all agree that we could find the savings elsewhere by doing a lot of other stupid, mean, unsafe, wasteful things and putting them into humane, integrated teams that can care for people. And there are, and we didn't have enough time to talk about it, but there are well worked out financing structures and pathways that could do this. So again, it starts with the money, but it's not about the money. It's about the money to create the teams, to create the space, to create the time, to have relationships and to be seen and known and to meet a differential body of needs over time that ultimately create health, happiness, and flourishing.
Of happiness and flourishing. It's a good place. Maggie, I think this is a moment where we change the approach. Back to you.